Welcome to today's webinar. This is Dr. Marnie Peterson. I am the Outreach Coordinator for the Antimicrobial Stewardship Project, which was launched last year by the Center for Infectious Disease Research and Policy at the University of Minnesota. It is my pleasure to welcome our participants to today's webinar, which is titled Assessing the Impact of Antimicrobial Stewardship Effects in Acute Care Setting. We have two outstanding expert panelists today, Captain Arjun Srinivasan and Dr. Rebekah Moering. A little bit of background about our panelists today. Captain Srinivasan is Associate Director for Healthcare Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention, CDC's National Center for Emerging and Zoonotic Infectious Diseases. He's an infectious diseases physician by training, and he oversees several CDC programs aimed at eliminating healthcare-associated infections and improving antibiotic use. Today, Dr. Srinivasan leads CDC's work to improve antibiotic prescribing and works with a team of CDC experts researching new strategies to eliminate healthcare-associated infections, and he's also a research colleague of Dr. Moering. Rebekah Moering is an assistant professor of medicine in the Division of Infectious Diseases at Duke University Medical Center and the Durham VA Medical Center. She is also a member of the physician epidemiologist team leading the Duke Infection Control Outreach Network, which is a network of more than 40 community hospitals. Her research interests include defining measures of impact for antimicrobial stewardship programs in community hospitals, and also improving antibiotic use through implementation and evaluation of core elements of hospital antibiotic stewardship programs. Both of these expert panelists have authored numerous articles in peer-reviewed journals in healthcare epidemiology, infection control, and antibiotic use and resistance. Just a little bit of background for participants to be aware of. You are encouraged to submit questions and can do so via chat box. And those comments can be, the chat box at the lower bottom right-hand corner of your screen. You can type in the question. Please note that your lines are all muted, so the way that you'll be able to communicate with our panelists today is via this chat box. So please do so at any time. So with that, I'd like to thank our participants for joining us and also our panelists, Captain Srinivasan and Dr. Moering. And I would like to invite Captain Srinivasan to begin the webinar this morning.
Thank you so much, Marty, and thank you to all of you for giving of your time to attend this webinar. All of us know that the most valuable resource that any of us has is time, and so we hope that we will be able to maximize your use of this hour to talk about measuring for impact in antibiotic stewardship. And when we think about measurement, I think it's important to begin by thinking about the goals of our stewardship programs, because I think that is what should inform our measurement approach. We know that our primary goal in antibiotic stewardship is better patient care. And I think that is intuitive to all of us who do antibiotic stewardship, but it's not always something that people outside of our stewardship programs understand. I think a lot of times people who are not intimately involved in antibiotic stewardship think that reducing antibiotic use or saving money are the goals of our stewardship programs. And that's simply not true. For example, getting broad-spectrum antibiotics into patients quickly is a goal of antibiotic stewardship in patients who might have sepsis. That's not about reducing use. That's not about saving money. Yet, that is an important part of antibiotic stewardship. I like to tell people that the goal of antibiotic stewardship is optimize better patient care. And reducing antibiotic use and saving money happen to be desirable side effects of antibiotic stewardship because in many instances, in most instances, we tend to overuse antibiotics. But our primary focus really is on improving patient care. And if that's our goal, then what should our measurement strategy be? What are we looking for in our measures of our stewardship programs? Well, we want measures that will help us identify opportunities to improve that patient care. We need to know if the improvements that we're making are having the intended impact. And of course, we always want to be sure that the things that we do, the interventions that we do, aren't harming patients. And so we always want to be cognizant of the potential for what some people like to call balancing measures to look for any potential potential unintended consequences. Given that, I think we can kind of divide our measurement for antibiotic stewardship programs into kind of two broad buckets. One, of course, is measures of antibiotic use. If we're about improving antibiotic use, then we need measures of antibiotic use. And those can fall into, I think, three different types of categories. We can look at large national assessments of antibiotic use, but more importantly, and I think much more actionable, are facility or practice or even provider-specific assessments of antibiotic use data. And of course, we can look at assessments of appropriate antibiotic use. So those are the different ways that I think we can measure antibiotic use. But of course, there are a number of other types of outcome measures that we're very interested in for our antibiotic stewardship programs, right? Antibiotic use is not really a patient-focused outcome. Our patients don't care overall if the antibiotic use in our hospital is going up or down. They care about these kinds of things. Clostridium difficile, whether or not they develop an antibiotic-resistant infection, infection cure rates or treatment failure rates, adverse drug events, their length of stay, and not directly of interest to patients, but certainly of interest to policymakers and to the public at large, are, of course, costs. So these are the types of outcome measures that I think many of us think about when we're trying to decide what we might want to measure for our antibiotic stewardship program. So when you guys are considering measures and when we consider measures at the national level, we like to think about what the qualities of a perfect measure would be for antibiotic stewardship. And this is really where I think most of our discussions about measure should begin. We know that an ideal measure should have all of these characteristics. It should respond to an intervention. So if I improve use, my measure should move the way that I would expect to be reflected by that improvement. It should be consistent and reproducible, certainly within your facility. So if you're measuring something over time, you should be able to follow this measure. But ideally, we would love to have a measure that's consistent and reproducible between facilities. We know that facilities want to be able to benchmark and compare their performance, and the only way that's possible is if the measure works the same for me and my facility as it does in yours. An ideal measure should be relatively easy to determine. The data should be relatively accessible in order to construct the measure. And when we're thinking about a measure for antibiotic stewardship, we of course want a measure that's largely dependent on antibiotic use. We know that most of the outcome measures that we think about are multifactorial, but we really would like to focus on things where if we feel like if we make improvements in antibiotic use, those outcome measures are going to move. And so I think for us, as we think about stewardship, we know that we don't have measures that have all of those ideal characteristics. And so we have to think about what are the measures that we want to use. And so I think there are some kind of important unanswered questions when it comes to stewardship measures, and we will come back to these at the end of our talk. But I wanted to lay those out up front so that you can be thinking about them as you hear Rebekah's presentation. So firstly, how do you assess the impact of stewardship on outcomes that are multifactorial? And again, this is most of the outcomes that we're interested in. How do you best risk adjust these stewardship measures? And that obviously becomes ever more important as we think about trying to compare performance on these measures between facilities. And do we need or want stewardship measures that eventually could become part of public reporting and the pay-for-performance system? We know that those are big drivers of improvement in healthcare, and so do we want antibiotic stewardship measures that eventually become part of that construct, the public reporting and pay-for-performance construct? And so with that, I am going to turn the presentation over to Rebekah. Rebekah has done so much work, really important and pioneering work, in thinking about measures of antibiotic stewardship, and so she's going to share some of what she's done with us today. Rebekah?
Thanks so much, Arjun, and thank you to Marnie and CIDRAP for inviting me to participate in this webinar. And so for the next part of the presentation, I'm going to really focus on a paper that has come out in CID recently that goes through an expert panel process that Arjun and I did about a year and a half ago now, where we really focused on trying to select metrics for acute care stewardship programs to help really show the impact of stewardship interventions. And this is the paper, and this is part of a larger project that I'm working on with Arjun, which is supported by the CDC Foundation. So I think this slide kind of echoes a lot of what Arjun was outlining in the beginning, that when we think about ideal metrics for stewardship programs, we want to make sure that they are tightly linked to improved antimicrobial prescribing, really meaningful for clinicians and public health, and feasible to monitor, whether it be directly out of an electronic health record, or if we do have to do some chart reviews, that it be minimally burdensome in terms of the data collection requirements. And we know that for most metrics, this is something that may not be attainable. It may be a complete unicorn, a mythical creature that does not exist to meet all of these criteria. But the point is that we don't need that mythical unicorn. We just really need a workhorse, something that really helps us make decisions, helps us know where to put our efforts, and helps us prove that what we're doing makes a difference for patients. So just to outline our goals for this study in stewardship metric selection, again, this applied mostly to acute care hospitals. One, we want our metrics to show our impact on patient care. Second, we really want our metrics to help us determine how and where to really invest our stewardship time and our personnel efforts so that we can really have data-driven programs instead of doing what we think is right, being able to show that what we're doing matters and makes a difference for patients. And then thirdly, we really wanted to get into measurements that were actually on the patient level. So not just looking at metrics on the large population level or maybe even unit level, but really getting down to the patient level measurement. And that's because a lot of what we do in stewardship is actually patient level interventions, reviewing an individual patient, provided directed feedback for that individual patient. And a lot of that activity is also the most time-consuming. Most resources have to go in those types of interventions. So this is why we really wanted to try and identify metrics that could be measured on the patient level. And then again, feasibility. Metrics that can be routinely measured and tracked, ideally from electronic data. And then for this study, we really weren't trying to address the public reporting and accountability. And the reason for that is just many of these metrics are still so early on in their development that understanding, their consistency between sites or, if it's something that you really can impact, we're still so early on in this development process, we didn't feel like we were ready to really address that question about public reporting and accountability. So as we define what we were trying to do, we had to define what a patient-level intervention really meant. And for me, that's an intervention from a stewardship program that involves reviewing an individual patient's clinical data and their management. So what antibiotics is your patient given? What infection do they have? What's their renal function? All of that clinical data that we use to really assess the appropriateness of antibiotic use for an individual patient. And that could be through chart review or personal discussion or your rounds for stewardship. And then delivery of a patient-specific recommendation from a stewardship program to the clinical provider. So really looking down to the patient level, evaluating that patient, and provided directed patient-specific recommendations. So as I mentioned, this is part of our larger project, and really this study was aimed to answer the number one question, which is defining standardized patient safety outcomes and process measures that are meaningful and practical for hospital stewardship programs. Part two of this project is then going to be to develop a tool that can be implemented at a variety of hospitals and for a variety of different types of interventions. So this really, this paper really addresses that first goal. But just to put this in the larger picture, and I'll give you a little bit of preliminary information about the larger project at the end. So in terms of developing our kind of list of metrics we went through two processes for that. And I'm going to focus on the first process, which was our expert panel process that we went through. And this was a modified Delphi approach for a consensus building where we identified a group of experts, surveyed them, had a discussion, and then surveyed them again to come up with our list of metrics that we felt were going to be most valuable for our hospital stewardship programs and also feasible to measure. As the second part of that, we also got input from 5 pilot hospitals that I collaborate with in the Duke Health System, as well as the Duke Antimicrobial Stewardship Outreach Network, to really see what active practicing on-the-ground stewards really feel about these metrics. We sampled this group of 5 hospitals to have differing IT systems and resources, differing goals for their program, but all of our pilot sites were actually doing patient-level interventions as part of their stewardship programs. And then in the end, we want to come up with this list of metrics that we think is both relevant and feasible. So to start this process, we did what everyone does, and that's a really big, fat lit review. We did a big PubMed search on any type of articles that address stewardship as well as measurement, and really tried to keep this as broad as possible. So not only papers that actually tested and utilized measurements, but also proposed different metrics. And so there's, this paper is not the first that have tried to kind of come up with a metrics list for stewardship programs. There's a lot of opinion out there. So we included those opinion papers. We included real, actual interventional studies that use different metrics, and really tried to take a very broad view of including as many possible candidate metrics as we could find in the literature. And that, you can kind of see that flow chart. We did apply some exclusion criteria. We were focusing on the acute care setting, and we were focusing on these patient-level interventions. So interventions that were more like guideline or kind of policy-driven that didn't really involve that individual patient review and feedback, we excluded. We also excluded things that weren't related to stewardship that made it into our PubMed query. And then we added any primary references that we found as we reviewed that first set of articles that came in. And then we extracted from those articles that met our inclusion criteria a bunch of candidate metrics, and that was actually 694 metrics. And we divided those into the categories that you can see there: clinical outcomes, unintended consequences, utilization metrics, process measures, and then financial outcomes. And then kind of consolidated all those metrics that we pulled out, deduplicated them, and that resulted in 90 metrics moving forward for rating by our expert panel. So our expert panel we assembled with the help of our CDC friends, asked physicians and pharmacists from across the U.S. that are actively working in stewardship programs. Many of these were academic researchers as well as healthcare epidemiologists. We tried to get a good sampling from East, West Coast, and the Midwest, all across the U.S., and also included folks from the VA system, the CDC, and pediatrics. For our first part of the expert panel process, we did a survey. And again, we broke up the metrics into our 5 different categories that you can see on the left there, and then asked our experts to rate each of those 90 metrics on 4 different criteria. And these criteria are very similar to what we've been talking about. 1, that the metric has to be associated with improved prescribing of antimicrobials. 2, that it has to be associated with improved patient care, which is the goal for all stewardship programs. 3, that it has to be useful in really targeting your stewardship efforts and your personnel resources. And 4, that it's feasible to monitor. And that 4th criterion, D, is the one where a lot of the discussion ended up happening. We also encouraged our experts to give us additional suggestions on any new metrics that we may have left out in terms of our first step in the lit review. Ask them for feedback on the description of the metrics, ask them for open text comments, and really tried to also just really engage our expert panel to add anything that we may have missed in our first steps of the process. We then, in terms of ranking, we used a Likert scale and looked at the mean and 95% confidence interval for each of the 4 criteria for each of the 90 metrics. And we had this rejection and acceptance criteria that you can see there, as well as decided to remove any metric that was rejected in 3 or 4 of the criteria, retain anything that was completely accepted in 3 or 4 of the 4 criteria, and then anything in the middle we just left as equivocal, open for refinement and reevaluation during the panel discussions. After that first written survey, we went through a panel discussion, which was the most fun part of this project. This was led by a moderator and one of our friends from CDC, who is a whiz at this, at engaging all the expert panelists with some open-ended questions, inviting feedback and refining and revising the wording of the metric descriptions, really giving the rationale for, rating a specific metric high or low, verbalizing their experiences with specific metrics or their lack of experience, and then, of course, invited to add any other metrics that we may have missed in our initial list, and then confirmed any removal of the metrics that didn't make it through on that first round of the survey. So this is the outcome of that first round 1 survey, as well as the expert panel discussions. We ended up retaining or having equivocal ranking of 28 metrics, refined 10 of them, added 3 new ones, and removed 49. So I think it was easy for our expert panel to say, look, this is really not helpful, or this is too confusing for anybody to use. We just need to drop that right now. And the major step in this were that all the financial category metrics were eliminated. And I think this goes back to what Arjun was presenting in the beginning, is that when our focus is really on patient care, the financial and cost metrics did not seem relevant. And so that first criteria, that it has to be associated with prescribing, and that second one, that it has to be associated with improved care, the financial metrics really just didn't meet that criteria. So the ones that did make it through the discussion part of our panel went on to that round 2, and we had 41 metrics left. And we really used the same method for the ranking on a Likert scale, but this time our experts had all the insight from the discussion from the panels, had a better understanding of what we were describing with each of the metric descriptions. And at the end, we were able to come up with a final list of 6 metrics that were accepted in all 4 of our criteria. And we deemed those 6 metrics ready for immediate reuse and tracking. So these were metrics that met all the first 3 criteria, as well as that feasibility criteria, number 4. And then we came up with this second list in a group 2 of metrics that were identified as useful, but that last criterion of feasibility was still really uncertain and unclear. And those, we had 14 metrics in the end there that we believe should move forward to really some more feasibility testing and implementation work before we could recommend them for immediate use and tracking. And this is the table that really shows which metrics made it into that ready for immediate use and tracking, that group 1, and then group 2, identified as useful but questionable feasibility. And I think it's pretty striking when you look at this table, that first category of clinical outcomes, none of the ones in that category made it into group 1, and only one made it into this group 2 with some questionable feasibility, and that was readmission related to infectious diagnoses. In the unintended consequences category, we had 3 make it into the group 1, 2 measures of C. difficile, and then drug-resistant infection. In the utilization category, in the group 1 metrics, we had days of therapy numerators over admissions and over patient days. And then in the group 2, we have days of therapy over days present, which is the denominator used in the CDC's National Healthcare Safety Network's AU module, antibiotic use module. So there were still some feasibility questions about this days present metric at the time of our expert panel evaluation. In addition, we have metrics that really aim to measure total duration, so both in-hospital and out-of-hospital duration of antibiotic use. And then in terms of process measures, you'll see this is also pretty unbalanced. In the group 1, ready for immediate use, only redundant therapy events made it into that list, whereas there were a lot of other potential process metrics, including appropriateness metrics in this group that really our expert panelists felt that they were probably useful and relevant for patient care, but their feasibility was really still questionable and uncertain. So to try and just wrap this up into some concise conclusions, we were able to achieve consensus amongst our expert panel, but there's still a lot of uncertainty remains about what exactly to measure and how to exactly measure it. It was very clear in our process that C. difficile is a really top outcome for stewardship programs to tackle and show their impact. And then overall, there was just a reluctance to accept those hard clinical outcomes like mortality, length of stay, readmission as a way to show stewardship impact. And there were many reasons for that. Probably the main two are that these are very rare outcomes, especially death. And also, so if you're looking at this on an individual hospital level, it's going to be really hard to show that you changed or moved the needle when it's such a rare event. And also that there's so many other intervening factors and confounders and other things going on that are unrelated to stewardship quality that could affect that outcome. So overall, just a reluctance to really accept that clinical outcomes. The days of therapy utilization metrics over multiple different denominators was the preferred measure for antibiotic use among our experts. But there was also a lot of interest in exploring other antibiotic use-based process measures, such as the redundant events and also de-escalation events. And I think, that's an area where we really could see some more development in the future. Drug-resistant infections. So this made it onto that group 1 list, but it still is pretty broad and pretty vague, even after our panel process. And this was one area where I felt, maybe some even more dedicated consensus building could be done to really identify which drugs, which bugs we need to track in terms of drug-resistant infections that are relevant to stewardship specifically. Although I really believe that, proving that you've reduced drug resistance is really just the holy grail for stewardship. It's what drives us to do what we do in most situations, and is something that is a big prize for stewardship to show impact there. But I think that, depending on which bug and which drug you're picking, the rare event problem could be an issue for this outcome as well, in terms of showing impact on the local level or individual hospital level. Also, our panel really spent a lot of time talking about feasibility barriers and their personal experience with each of these metrics and trying to get this data out of their systems. And so there are some real barriers out there to getting them. I think many times it's IT priority or competing priority problem. But electronic data really is promising to be able to get at some of these measures, to be able to use them as part of our programs. And then we identified several metrics that really need some more just development work and some more thought put into them. Several in the group 1 category still need some more thought. Drug-resistant infections is one of those. And then most of the ones in group 2 really need some more work, some more research to really come up with a standard way that we can measure this consistently within our hospital as well as outside of our hospital. And there's some real challenges there. I did just want to point you guys to the supplemental material with the paper in case you were interested. We provided all 90 of those metrics in a table and actually showed the scores for each of them from our panel. So if you really wanted to dig down into the numbers and see where each metric of those 90 metrics fell out, you could dig down into that table, which is quite long. The other thing that you might find interesting is for the ones that ultimately were accepted, I also paraphrased the comments from the stewards panel members. So some of those are pretty interesting if you want to go in and check those out. So I think, coming to the end of this, we really wanted to show our impact on patient care, but our panel didn't end up selecting those patient safety outcomes that, we all really care about. We want to prove to our hospital leadership and our clinicians that we are making a difference on. So you're kind of left with this, but wait a minute, we're supposed to be really measuring patient safety, and we didn't accept those as experts. So I would say to that I would, of the individual patient safety outcomes, C. diff is probably your best bet for showing ASP impact. And I think, there's a number of reasons for that. One, it happens frequently enough for hospital level measurement and to show that you can actually significantly move the needle. And there's already great literature that shows that stewardship programs can reduce C. diff. So this is something that you can do locally. You can change C. diff incidence at your hospital. And it happens frequently enough to show that significant change. It's tightly linked with antibiotic prescribing, even closer than some of those other patient safety outcomes. I think you probably may reach a threshold effect at some point in terms of getting to the lower limit of being able to push down antibiotic use and avoid excess C. diff cases. And I think the other major discussion around C. diff is that there's a ton of C. diff that happens outside the hospital or is imported into your hospital. So there's a ton of work for stewardship and other prevention efforts that need to happen, not just within our four walls of the hospital. And then the other thing that I would mention with C. diff is it's so important to partner with the infection prevention program in your hospital to really impact that, and also understand what infection prevention is doing for C. diff if you are, rolling out a new stewardship intervention, so that you can understand the effects of infection prevention activities in light of the effects of your stewardship activities. Because we know that, cleaning, disinfection, and, testing, things like that also affect C. diff outcomes. In terms of our other typical clinical outcomes, like mortality and length of stay and readmission, these types of outcomes may actually be better as balancing metrics. So what I mean by balancing metric is something that shows that, of our patients that received our stewardship interventions, they didn't come to more harm than if we didn't do the intervention. And because so many of our stewardship-related interventions are related to shortening duration or providing narrower spectrum of activity, that, clinicians are worried that we're going to miss some cases where we undertreated and actually resulted in harm. So it actually might be, and the tricky part with these types of metrics is that they're so rare, it's hard to show that you've improved it. But it may be helpful to show that there was no change. And so that actually may be helpful in messaging with your providers and hospital leadership following your stewardship intervention. And as a bonus, most of these are already measured as part of utilization metrics and quality, so they shouldn't be as hard to capture, just to show that, hey, we followed it and it wasn't our primary outcome to change, but as a secondary outcome, it didn't change when we don't think we're causing harm. Sorry. And then finally, cure and recurrence are probably metrics that require research level resources to really accurately and measure well, because many of them will require longer follow-ups even outside the hospital, and actually coming up with a definition for what you believe is a cure. Certainly we have some of those definitions made as part of research, but it's harder to do that when you're doing that in more of a quality improvement. So I mentioned that this project was part of a larger effort that we have, and I just wanted to share a little bit of follow-up data to that. And so we basically went back to our 5 pilot sites after we got this list from our expert panel process and asked them to choose some metrics that would be relevant to their programs and to really move into that next step, which is that feasibility testing. And we asked all of our pilot sites to choose all of those Group 1 metrics, as well as 2 of the Group 2 metrics, the days of therapy over days present and the de-escalation events, to move forward into feasibility testing. And then we asked them to just choose among the rest of those Group 2 metrics, 3 or 4 additional ones that they were interested in pursuing and would match well with their own programs, as well as what resources they had in terms of IT. So just looking at this table, this is what our pilot sites chose. So the blue ones were the ones that we asked all 5 of our pilot sites to move forward to feasibility testing. And then the yellow ones from our table were the ones that our pilot sites ultimately chose of interest to them that they believed would help in showing impact of their program. And you can see of the ones that didn't get chosen, many of them were related to some of these culturing ones, and an error, which is kind of a more generalized one, also wasn't chosen. So we're kind of getting towards the end of the part where we asked for data from our sites and then have moved forward to the analysis phase for many of these metrics. And so this slide just shows you kind of where we are after time has passed. So the green ones are the ones where we actually got to acquiring the data and being able to analyze it. The yellow ones are the ones that we have run into data acquisition barriers. And then the red ones are the ones where we had both data acquisition barriers as well as difficulty coming up with standard definitions for them. So you can see kind of how that has fallen out with our experience. And of course, this is preliminary results. We're still working on this. But I think, this will give you a little bit of clue how this is going to come out with our pilot sites as well. And you can see again that this drug-resistant infection one, getting that at the patient level with our microbiology data has been a challenge in terms of moving this forward with our feasibility testing. So just to summarize, this is just a really active area of research with many open questions remaining. And so we really feel that patient-level measurement is challenging, but it's still really important to be able to show the impact of our individual time and effort that we place in stewardship. We need a lot more work on some of the proposed metrics, standardized definition, as well as feasibility testing. And then after the feasibility testing part, we have to show that we can impact these metrics with our work. So some demonstration that we can make it change with a stewardship intervention. I'd say that identifying appropriate antibiotic use continues to be a challenge, and that was one of the ones that made it into the Group 2 list, and one of the ones that we have struggled in working with our pilot sites to really make a standard definition for a number of reasons. But I believe that appropriateness still is an important outcome for stewardship, but that this may be one that we don't come up with a true standard definition for, that really we need to make those definitions on site and customize it to what our goals are specifically for our programs. But you could have a complete other webinar just talking about appropriateness metrics. So I'll just put that in Marnie's ear for maybe if she wants to do another webinar that addressed appropriateness. So that's the end of my portion of the talk. Just wanted to say thank you so much to my co-authors for this project, all of the experts that participated in the stewards panel, our CDC partners, as well as our pilot sites in the Duke Health System and in our outreach network. And feel free to contact me with follow-up questions if I don't get to your question during the webinar discussion today.
Thank you, Rebekah, very much for reviewing all of your research work to date and giving us some insights. Arjun now is going to return to these questions that he posed, and we're going to carry on with the discussion. So I'd just like to remind the participants, if you haven't already, please submit your questions via the chat box. And Rebekah, we did have one question before we begin these questions related to your presentation. When you mentioned redundant therapy, were you referring to double coverage of a particular organism, such as perhaps doubling on anaerobic coverage or broad spectrum?
Yeah, so ours was more looking at the spectrum of coverage. So I think the double anaerobe is a great example of that. So, for example, giving both piptazo and flagyl together, when piptazo alone would have covered anaerobes, or flagyl alone would have covered anaerobes. So using two agents to cover the same spectrum of pathogens. So As we have gotten further through the project, we know that there's several papers already that have looked at that double anaerobe combination, but we also wanted to look at people that were using 2 antifungals in the same patient, or double pseudomonal coverage, or double, anti-MRSA agents. So there's a couple of different spectrum groups that you could look at potentially, but certainly the majority of work already has involved the double anaerobe combination.
That's great. So this is Arjun, and we've got those overarching questions back up on the screen there. So if you have comments or anything you want to add about those, or respond to those, or react to those in any way, please do chat into the chat box. I do see another question from the Indiana State Department of Health, and very glad to see you guys on the line. They would like to implement a pilot study using stewardship commitment provider posters, but they're encountering barriers in collecting antibiotic use data to establish a baseline. Any advice on how to encourage facilities to provide data? And I assume you're focusing on the outpatient setting for those commitment posters. They've been best studied in the outpatient settings. I'm not sure, I'm not aware of any data, Rebekah, I don't know if you are, of any data using those same type of commitment posters on the hospital side. But, getting facilities, practices to provide data, be they outpatient practices, nursing homes, or hospitals, remains a challenge. A couple of ways you can go. Let's take it setting by setting. I think in the outpatient setting, there are other ways to get at some of this data. So, for example, there are some states that are using their Medicare all-patient, all-claims database to get access to prescription data. And so I know New York, for example, New York State has done that. And so Indiana, you guys might be able to access some of your all-payer, all-claims database, at least for Medicaid, I think. That's where you could have some of that information. And we also do get some of that information here at CDC through a company called IMS. And so would be happy if you want to reach out to us to let us know if you would like to partner with us to begin to look at some of that data. Feel free to send me a note, and I can connect you with folks who might be able to provide some of that information. For the hospitals, the best way to get at that data is through these types of collaboratives. If you're working on a performance improvement effort, there are several states that have taken that route, Colorado, Washington State, and they have been successful in getting hospitals to share data as part of performance improvement efforts, and so that may be a way to go there. So those are just some general thoughts on ways to engage facilities, but I think certainly that issue is definitely a challenge. Other questions come in. Do you have recommendations for stewardship measures for infection prevention to monitor? Besides infection and resistance rates, I am an infection preventionist, and we are looking for ways to get involved. I think that's great. I think that stewardship is a really important collaboration between infection prevention and the antibiotic stewardship team. And Rebekah, let me turn that over to you. You occupy a kind of a unique position because you do oversee activities both for your Duke Antimicrobial Stewardship Outreach Network as well as the Duke Infection Control Outreach Network. So I'm sure you guys have had a lot of thought and discussions about the interconnectedness of infection prevention and antibiotic stewardship. And do you have some thoughts on ways that IPs could get involved and for measures where IPs could be involved?
Yeah, and thanks for this question. I think it's great for our IPs to get involved and really be seen as a partners in stewardship because there's so much baseline knowledge that you guys have that can really help a stewardship team. And I think, one thing that I just in working with a lot of our sites in our outreach network as well as here at Duke, you guys have this intimate knowledge of the National Healthcare Safety Network, doing surveillance as well as reporting it. and how that works. So this is an area where a lot of our pharmacy colleagues are just kind of getting a taste of what that is, especially as more sites really sign up to report to the NHSN. So I think that's certainly an area where IPs can help as you are kind of administrators for the NHSN at your site. Understanding, for example, unit mapping. That's always kind of a unique thing that, most of our pharmacists maybe haven't thought about how to categorize a unit into one of these standard categories, for example. I certainly think also, because you guys are reviewing each one of those C. diff cases, in the chart and looking at each unit where that's happening, I think you have a really great understanding of the types of patients and where that's occurring. And if you can kind of share what you're seeing in your chart reviews with your stewards who are more focused on the antibiotic use part of it, I think that's another really amazing way to collaborate, to really work together on trying to avoid those extra C. diff cases. And if you can, get it at the infection prevention angle, as well as really addressing the antibiotic use angle, your success rate is going to be much better.
Rebekah, this is Arjun. I think that's such a great suggestion. Have you seen any kind of standard forms or tools that people have used to review, like do a very quick and focused review, like when there's a new case of C. diff, to go and look, what antibiotics were they on, how long were they on them, why were they on them, were they on PPIs? I've not seen any tool. I don't know if you guys have developed or seen any quick abstraction tools that people might use for something like that.
Yeah, so I think we've developed one internally and then shared it around, and we have put a bunch of criteria into a C. diff MUE, medication use evaluation, but it's not really a med use evaluation, it's more of a syndrome evaluation to try and identify ways that we can both manage C. diff specifically in terms of its antibiotic use, but also avoid those antibiotics that may contribute to development of C. diff. And so PPIs is definitely one of those criteria that's on there, but also trying to evaluate clinically the severity of disease to make sure that they're managed appropriately with the right antibiotic after they have C. diff, because we know that if we can get our patients on the right management for C. diff, it could potentially reduce their shedding into the environment and their risk for other patients as well. So not only identifying those patients, getting them on contact precautions, but managing their C. diff to get them feeling better faster, that can help protect other patients too.
Yeah, that's a great suggestion. This may be a situation where, a meeting with the infection prevention team and the stewardship team to try to think about, well, what information, if we're going into the chart anyway, what information would be most useful to you from a stewardship perspective with this particular case. I don't see other questions. Rebekah, I had one for you. You advise a lot of hospitals that are kind of just beginning in their stewardship programs. What do you recommend to them in terms of measures? How many things do you encourage them to measure when they're just getting started out, and what do you encourage them to measure?
Yeah, so I think, one of the main things we do is try to understand what resources they have already to be able to kind of pull in and really put into place as they think about what they want to measure. So understanding the amount of resources you have for measurement for stewardship is important, just as a starting point. But certainly also just using what you have already. So in many cases, our stewardship program really hasn't reviewed that C. diff data or that MRSA, the VRE data, that their infection prevention programs are already actively, tracking and reporting on regularly. So just having that understanding of what's already there is step one as well. And then we push pretty hard to be able to get to the antibiotic use data as the next step. So being able to actually measure days of therapy from electronic medication administrations and barcode administrations is very important, not just orders data or DDDs, but being able to get down to days of therapy, we think is really important, because we want our folks that we collaborate with to be able to use that data to really find their targets for their stewardship program and really focus their efforts. So I would say, yeah, so understanding what's already there, understanding what IT resources you have to focus to it, and then helping gain support for actually getting to that antibiotic use data.
Yeah, and I know that antibiotic use data is important and often a challenge. Are there any tips that you might have? Are there barriers that come up consistently, or approaches that have been very successful in helping folks get at that days of therapy, that antibiotic use data?
Yeah, so I mean, I think for us, we have been able to work with each one of our hospitals that collaborate with us to really be able to get into that medication administrative record data. I'd say that most electronic medical records now have those tables that are there. You just have to find a way to get to them and find an IT person that has the skills to do it. And sometimes that can really be a challenge. I think the bigger challenge for most sites is actually elevating the priority for that IT request over other competing requests within their facility. And I'd say my best advice for that is to really engage your hospital leadership to really fight for stewardship there. And I think, as all of our efforts are showing, certainly the policy changes, the Joint Commission standards help in bringing stewardship to the forefront in terms of institutional priority. But I think, winning those messaging battles with leadership really makes the biggest difference in terms of trying to elevate the priority on the IT request list.
Yeah, I think that's a really good point. I think when we began working on a lot of this, Rebekah, several years ago, one of the big challenges was that a lot of facilities didn't yet have barcode or electronic MARs, and so they maybe didn't have access to the types of raw data that could produce days of therapy. But increasingly, it sounds like, at least if you look at surveys, and it sounds like based on what you're saying in your experience, the vast majority of hospitals now do generate the types of information that would support having the days of therapy per 1,000 patient days. And it's really a matter of working with your hospital, with your IT staff, in order to get access to that data. Do you think that's generally true? Yeah,
no, I would agree with that statement. And I think, it's been relatively rapid where our EMRs are now providing the ability to get to that, but you just have to have somebody that can get under the hood and get to it.
Yeah. And in terms of that, get under the hood person, is that, if people are looking for that person, is that usually someone in the IT department? Is it usually someone within the pharmacy division who might have access to that? Do you have some tips on where you might send people, or where do you guys go first when you're looking to get access to that data?
Yeah, I think it varies, but certainly there may be an individual IT person devoted to the pharmacy. So a pharmacy IT person is usually the ideal individual to try and get at this data and help to validate it and pull it appropriately. But sometimes we do work with analysts that have more experience in other types of data, and they have a lot of learning to do once they start trying to get into the EMR data and understanding how it's structured and how it gets pulled out. And so sometimes it's more of a learning process to be able to get it out. And then other sites really have that pharmacy IT representative that is a real whiz and can get into it pretty quickly.
Great.
Rebekah,
here. Oh, go ahead.
Go ahead, Arjun.
Oh, I was just going to read the comment. People probably can see this, but I'll just read it. It says, I'm from a community hospital in CIDRAP. It just relates back to the discussion that we were having about the reviewing of the C. diff cases. And so this person works with their infection preventionists to review all the hospital onset C. diff cases and review the antibiotics and proton pump inhibitors. They have found that to be very helpful, and they just have a little simple Excel tool. So what a great suggestion, and thank you for that comment. A question that's come up here is any suggestions on how to incorporate monitoring of discharge antibiotic prescriptions in looking at total overall antibiotic use? Rebekah, is this something that you guys have tackled at any of your sites?
Yeah, so this is certainly an area of interest for our group, and was an area of interest for the expert panel through the stewards panel. And so you will notice that in the utilization category on our table, there were 2 metrics in that group 2 list that needed feasibility testing. That was looking at total duration. So I think this is an area that we really, it's early on, but we should really start looking at and tapping into to be able to measure, because we think of our patients as whole people, you know, both in and after they leave our hospital. We want to impact their total use, not just the days that they have while they're here in our hospital. So getting at those discharge antibiotic prescriptions, as we've tried to go through this feasibility testing with our pilot sites, has been mixed. So of our kind of 3 sites that tried to get at this data, 2 out of 3 were successful. And I think the difference was that in the 2 that were successful, the outpatient data was actually of interest to the pharmacy administrative staff as well as the stewardship staff, because there was because the discharge drugs, actually many of them were filled at a retail pharmacy that was at our outpatient pharmacy, basically. So there was interest in that data for other reasons, and so that helped move up the priority for being able to access that data, just as in terms of institutional priority. But many of these are now electronic. So I know for like Epic hospitals, the discharge antibiotic prescriptions do get recorded. And also, like, which retail pharmacy it goes to gets recorded. So getting at this data is possible. Again, it is having the money to get the extractor under the hood to get that data out into something that you can analyze. But this is something we're actively working on trying to measure, at least for 2 of our 5 pilot sites, too. So stay tuned for that. You might see something at ID Week from us on that.
That's great. And Marnie, I'm going to turn it back over to, I don't see, one last one. When looking at discharge antibiotic utilization, what denominator do you recommend? Days present or patient days would not be accurate. And so, yeah, you know, this is something that we've talked about quite a bit. What kind of denominator do you use for post-discharge? And Rebekah, what are you guys looking at when you look at your post-discharge antibiotic prescriptions?
Yeah, so I think that is going to be tough. I think we are looking at just duration. So most of it, we're looking at just the numerators in this case, and we'll probably just use an individual patient as a denominator.
Yeah, and I think that's right. You know, I think a lot of the work here, when you look at this, is really looking for opportunities to make durations of therapy more in accordance with treatment guidelines. And so the approach that we've taken in looking at this in some large data sets is looking at discharge diagnoses, or looking at diagnosis codes for things like meningococcal pneumonia is the one that we looked at. And so we didn't really have a denominator. We looked, though, at lengths of therapy for patients who had a discharge diagnosis of community-acquired pneumonia.
Arjun, thank you so much. So Rebekah, I have a final question before we close, or if we happen to get another question from our participants. You mentioned that, you know, drug-resistant infection rates were one of your recommended ready for immediate use, and then you've piloted this and you've got problems with it. There's some barriers, there are feasibility barriers. What are those? Because it seems like some of that data would have been already within the antibiograms.
Yeah, so that's a great question, Marnie, and one that we've thought about a lot. So antibiograms certainly can give you great information about kind of the prevalence of resistant pathogens that you're seeing at your site. But our goals for this project were to be able to get it down to the patient level. So being able to pull an individual patient out and understand whether they acquired a drug-resistant infection. And so being able to get it down to an individual patient requires an extraction with, you know, a patient identifier, an admission identifier, and being able to then link that back to, you know, antibiotics they got in the hospital. So getting it down to that really granular patient level is a different request than asking for kind of numbers of resistant pathogens over a year. And so we found that, at least for our pilot sites, these data come out of varied systems. So many times, even if you have like a specific EMR, like for example, Epic, your lab information system is a different system than Epic. And so that adds another layer of complexity in terms of getting this data out of your system. So I think also, the CDC has been interested in getting folks to report resistance data through the R part of the AUR module, and being able to get data out of varied, lab information systems in a standardized way has been really challenging thus far. And I don't know if Arjun wants to speak to that at all. I know there are other sites that have been working on that project.
Yeah, I don't have anything to add. I think it's something that is work ongoing.
Yeah, ongoing work there.
So, so more of a, once again, in collaboration with your IT folks, trying to set these as priorities, and then how do we go about collecting that data. Well, thank you so much. Arjun, if you'll just advance to the last slide, this is kind of my last thank you, and one more. The final, there we are. So this concludes our webinar then today, as we're at the bottom of the hour here. So I would just like to mention to all of our participants that this webinar is recorded, and we post these webinars, this one and as well as ones we've had in the past, at a CIDRAP YouTube channel. So if you go to our website or go to the youtube.com/user/CIDRAP ASP, you'll find our webinars there. I'd just really like to sincerely thank Arjun and Rebekah for your time today and insights. This has been very interesting. Seems like it's an ongoing process, so we'll stay tuned, but I really think this is going to help us impact. Part of fulfilling of the mandate within stewardship is what outcomes can we reliably measure and adapt those to our settings. So thank you all so much.
Thank you, Marnie.